Hi, I'm Paul Hodges and I'd like to welcome you to the ICS Live Lounge to talk about the physiotherapy workshop that we did this morning. I'm happy to have with me Linda McLean from Canada and Grania Donnelly from Ireland. And what the session this morning we had was on ultrasound imaging and the pelvic floor. So Linda, first if I ask you, can you tell us a little bit about what the session was about?
Sure. So our session was a mix of theory around ultrasound and how we can use it in clinical practice as well as in research. So identifying a need for both testing for the robustness of the measures we use, but then also understanding that in clinical practice, when we use the systems for biofeedback, we're not necessarily always needing those same measures.
Great. So, Grania, what do you think are some of the messages you'd like the audience to have got from the session this morning?
I really hope that everyone sees the use for point-of-care ultrasound within whatever realm they work in. And we went through a lot of things, including how we can measure different parts of the pelvic floor morphology. And that's really useful, particularly in the research context, as Paul and Linda are doing. But it can be used within clinical practice if you have a really interesting case or you're trying to evaluate something. But typically on a day-to-day basis, I very much eyeball a lot of those structures and look at the movements or look at their position in space, and I don't, for each individual patient, measure everything. So I think sometimes clinicians can get bogged down thinking what's expected when you're using ultrasound, and as I say, it's a really useful dynamic tool that just becomes an extension of the assessment you're already doing. Would you say that's fair?
I think that's fair, and I think also it's important to understand what those measures are in order to be able to read the literature and to interpret any research papers in a meaningful way.
Really important. And what are some of the things that you think that are important about how to interpret the ultrasound? What's it telling you? What can it add that you would not normally get from other forms of assessment?
That's a great question, and I described it today as ultrasound giving us the eyes to what we've already heard and palpated, because as clinicians we're taking meaningful information and we're objectively assessing in any means that we can, and typically we do digital vaginal examinations, but we're doing them blind, and so we're imagining what we might be seeing or feeling. And I think that the ultrasound offers a layer for us actually to confirm some of those working hypotheses or maybe challenge what we were thinking. So it's just a whole other layer, another dimension. And it really lets us, my biggest thing for use is that it confirms maybe what I was going along thinking and gives us a more tangible measure. Even if we're not objectively going to the level of taking certain measurements, that visual layering I think is really important.
And what you said is really important in terms of in female anatomy there are other techniques that you have available to you to make assessment, and in male anatomy that's not necessarily the case. We don't have the same access to be able to assess pelvic floor muscle, so ultrasound gives us a unique opportunity to actually do the assessment, and particularly when we start to think about the finesse of different muscles. So in males it's particularly important to consider the sphincter, and that's really difficult to evaluate in any other way than ultrasound.
Yeah, because seeing your images this morning really consolidated the importance of looking at even that anterior component. So I think that was really useful for anyone who hasn't been using ultrasound to see maybe how they could utilise this tool to enhance their practice.
Another of the issues that was talked about this morning was about the physiotherapists using ultrasound and what training is required and what might be the process to get to the point where you can use ultrasound. Any comments around that?
I think we certainly lack official training and or standardization of any education for ultrasound. So most people I know are very much self-taught. They work with radiologists or with urogynecologists or urologists to learn approaches, but really I think we've taken it farther than that. And so I think we're in a place where as physiotherapists, if we're using these methods, we need to be developing our own educational content. I also think, certainly internationally there are different regulatory bodies that allow or don't allow certain things. In the province I live in, we're still not allowed to use ultrasound without a physician referral, even though they don't understand the measures we use with it. So it's very, very much dependent on where you're from, and some standardization and advocacy would be good.
And Grania, you've done some work developing some guidelines for the point of care use of ultrasound. Did you want to talk a little bit about that?
Yeah, so because of this problem that you've highlighted, Linda, we realised it is an ungoverned area and there's people training in different ways, and we thought we needed some standardisation. So we've started that process by creating a framework for point of care ultrasound within physiotherapy practice. And what that does is it allows our wider multidisciplinary team members to understand why we're using it and how, and that at present the use of it within a physiotherapy pelvic health context is not diagnostic. We're not looking for medical pathology. We're looking at the morphometry of the muscles and tissues. We're looking at what happens, and we're looking very much at functional assessments that may help us understand why someone's having the symptoms that they're having, but also as a biofeedback tool. And that's a really good use of it, because I think even as clinicians we can appreciate how much the visual of ultrasound adds to our practice, but can you imagine for the patient who has no understanding of the pelvic floor, no visualization in their mind's eye, and that really gives them a aha moment or a penny drop where they can see it, they can understand what's made that movement. So then they leave your clinic more confident how to continue that training that you've prescribed for them. So it's really useful.
And one of the things that's obviously really important is the technique valid and reliable? So are we actually measuring what we think we're measuring? And if we measure it twice, do we measure the same thing?
So I think we've got some work to do there. One of the problems is when you read the literature, a lot of the studies have been done by someone captures images, and then different people analyze those same images. And so we need to do more work at looking at really understanding what the variability is from day to day. But I think we can be good, and we certainly, if we come up with a standardized way to measure, I think we would have very good success with reliability. And I think we understand now a lot about what impacts the validity of our measures. And so if we're careful to watch for certain bracing tasks or certain behaviors that might change what we're seeing, we can then also have some pretty valid measures. And certainly when you see it on the screen, it's pretty clear what's going on.
Yeah. And I guess one of the critical things is that there is research that's been done to show that the things that the measures that we make in terms of movements of pelvic floor structures are related to muscle activity. So there's studies that have compared EMG recordings with the displacements and have shown that they are related. So there is validity.
Exactly.
But are there some concerns? Are there some features that we can't measure?
Clinically, it's very challenging because, one of the biggest confounders is intra-abdominal pressure. And in a clinic, you're not going to have someone have a nasogastric catheter to measure their intra-abdominal pressure, or maybe not even a pressure sensor in their behind to measure this. And so we don't really know, but that's where we can use our keen observational skills to really understand if we're watching for certain bracing patterns and we know that that impacts our measures, we can then correct those, and we can use the ultrasound to correct those in terms of biofeedback to then understand how much weight we would put on the things we're seeing. So I think we're in a good place. I really believe that we've got some good validation studies to back things up, and certainly we also have more to do, but it's coming.
And obviously one of the other elements of validity is when we use ultrasound, do we actually observe differences that help us understand in a patient what's different from the healthy system? So what kind of evidence do we have about the measures being different between people with and without problems?
So even things like we discussed in the workshop this morning, like bladder neck height. Now we just had a nice discussion about what reference line we should be using in terms of measuring it, but we have tools like that. So we've shown that if someone's bladder neck descends more than 25 millimeters, it increases their odds of urinary incontinence. But of course we know that incontinence is more complex than that, and there's more mechanisms at play. But even things like the retrovesical angle, so if that extends or becomes more obtuse when someone coughs or in bearing down or intra-abdominal pressure, that's another component that may compromise the ability to maintain that urethral closure pressure. So these visualizations layer on top of the subjective. I keep coming back, it's a layer of information to add to what you already have that may help you home in on the structure that might be relevant to this patient, whereas the next patient might have another mechanism at play. So I find it really useful I think it makes us better at differentially diagnosing within our own scope.
And in the male world, what we've been able to show is that there are features that discriminate between a man who is and is not continent after prostatectomy. And one of the critical features is it allows us to personalise, which is exactly what you've said about actually identifying which part of this complex system is actually not working. And in male anatomy, we can observe the bulbar cavernosus, the sphincter, the levator ani. We can see how they're coordinating, and we can observe the amplitude of activity and the timing and actually work out, well, where is the problem for a man. So it is actually a really useful technique for precision, and there is good evidence now to suggest that these features are different between men with and without incontinence. And one of the challenges is that some men don't regain continence, and this is allowing us to understand, well, when might a man be needing other interventions? So it can be really helpful.
Can I build on that, Paul, and say one of the questions you asked, and taking it back to clinically, what we measure, what we don't. One thing that I do regularly measure is pre- and post-void residuals, because I think this is a really clinically useful tool. How much can someone store in their bladder? How comfortable are they storing it? And can they fully empty their bladder? So that's something that doesn't take long. So developing your skills and your accuracy in that is really useful as a clinician.
And particularly important for male anatomy, because the most common urinary presentation in men is benign prostatic hyperplasia, and urinary retention is the key feature of that. So yeah, definitely a skill that we could develop. But does that take us out of the realm of what we do as physiotherapists by starting to measure bladder volume?
So when we were developing the scope of practice framework, we got quite a lot of pushback and resistance, because there's this line of medically diagnostic and working within a rehabilitation capacity. And I guess I looked at things in terms of, what are we doing clinically without ultrasound? And am I potentially diagnosing retention without ultrasound? Yes, I am. I'm looking at frequency volume charts, and I'm very strongly hypothesizing that someone's in retention. So this actually gives me a more valid confirmation of that. So I do think it's within our scope, and if we aren't doing it, who is? And are we creating barriers to people accessing the quite urgent help they need in some cases? So I think that it's important that we future-proof our profession too, because like other areas of healthcare, we look at MSK sonographers. My husband's an MSK sonographer. He can diagnose. He's a physiotherapist, because there's that level of training. And I think the future's bright for pelvic health physio, and I think down the line there could be the appropriate level of training that enables us to have some extended scope measures, perhaps.
Great. So what's the new frontier? What's next in ultrasound imaging?
I think it's really two things. I think one is really using the findings to understand things like who benefits from this particular intervention. How can we identify the person in terms of female anatomy who is going to succeed with conservative intervention? And we've done a recent study showing that when we measure bladder neck height, it can be strongly predictive of success or failure with conservative intervention. So I think that is one biggie. I think too, the time is right for some higher level clinical trials on biofeedback or ultrasound-based biofeedback interventions, where you really can tailor your intervention to what the deficits are that you see on the screen.
So our match-up trial, which is a trial of ultrasound-guided feedback for personalising management of pelvic floor training post-prostatectomy, the data has just been analysed, and we're about to do the stats. So hopefully next year at ICS we'll have the results of a trial that does exactly that.
So it truly is emerging.
Yes. Future?
The future, in terms of a focus, I definitely think that we need to get that level 7 training and establish that, so that there's no grey area of utilising this. And I think it will help our international regions as well, because if it becomes a standardised skill set that physios can build into, then other areas in the world will hopefully follow suit and allow the practice of that within clinical practice in terms of states and different things. But in terms of, what was the question, Paul?
The future of ultrasound.
The future of ultrasound, I think as ultrasound machines get more accessible in terms of cost and usability, I think that more and more physios are going to be using them, and I encourage that, but I encourage everyone to think about the scope of practice and governance issues surrounding that, and get your team of support and access the training that you can, and as I say, keep on top of the emerging research basically would be what I'd say, because the more we start to understand, the more we can enhance what we do in clinical practice with ultrasound.
And there's also advances in technology that we might be able to take advantage of. So things like you demonstrated the use of Doppler, so using colour Doppler to be able to see the actual motion of urine and incontinence. But there's also other techniques like shear wave elastography, and there are some discussions during this conference using that technique, and it's not easy, and it's fundamentally problematic in how to interpret it, but it's a new frontier that we should take on board and make sure that we develop guidelines around to make sure that it's interpreted in the right way and undertaken in the right way. Yep.
Absolutely.
Okay. So if there's any questions from the audience, we'd be willing to take some if there's some time available. We've got 1 minute, so does anyone have any questions they'd like to ask? Pose to the speakers? Yes? Mm-hmm.
Thanks. Hi, thank you for your discussion here. We also use the ultrasound in Israel, the transperineal ultrasound, and we found that is really comprehensive for us to see the evaluation. I want to know if you use specific measurement like the BND, bladder neck descent, or other measure in your diagnosis.
So
in part of the pelvic floor physiotherapy.
Mm-hmm.
So in terms of diagnosis, no, but we do use those measures to guide intervention planning. And so, for example, this whole idea of the bladder neck height, if it's sitting low, we know we're missing support. We know that we're going to perhaps have to work harder. So we're working now on standards. Like I think we identified something like an 11 millimeter descent was really predictive of success. So then you can use that to say, well, maybe this person needs to work in a different way or work harder. Certainly in men, it's very similar in terms, or it's more established in terms of some pretty fine parameters around who might develop post-prostatectomy incontinence.
And you use also the elevator hiatus and other measurement like the bladder neck angle and...
Yes, so levator hiatus, you need a 3D system, so we didn't discuss that in the workshop, but certainly you can use that to establish, whether there might be ballooning. You can also often see areas where there's a lack of support. So it's not unusual for us to identify that there's a lack of support in some of the pelvic organs that has been missed by a clinician or maybe not reported previously. So there are definitely applications there, but as physiotherapists, we're not allowed to diagnose. We send them back to their primary care provider for follow-up.
Okay, thank you very much.
Thank you.
You're welcome. So that brings us to the end of our session. I'd like to thank Grania and Linda for their valuable time, and enjoy the rest of the conference.
Thank you. Thank you.